Welcome to the S is for Screening event, the second live stream in the S is for Sickle Cell Disease series. Thank you for joining us. If you have any questions throughout the live stream, please log in to your Facebook account and post them under this video. We will try to answer them during the Q&A section of the event. My name is Samuel Misiani Mbunya. I'm an advocacy relations consultant and a member of board of directors at the Global Alliance of Sickle Cell Disease Organizations. I am delighted to be joined by my esteemed panelists, Dr. Charles Kiaga, who will be joining us very shortly, Dr. Lawrence Osei Tutu, and Chilufya Pikiti, who I will actually have them have their videos on and also unmute themselves so that they can introduce themselves. If we can have Charles, Chilufya Pikiti, just introduce yourself, and then we'll go on to Dr. Lawrence Osei Tutu.
Yeah, good afternoon, everyone. My name is Chilufya Pikiti from the Zambian Childhood Cancer Foundation, and I'm a parent with 2 children with sickle cell. Thank you.
Oh, hi, everyone. Great to be here. Nice meeting all of you. My name is Lawrence Osei Tutu. I'm a doctor. I'm a pediatrician. I specialize in treating kids and adults with sickle cell disease, and I also treat children with cancer. I'm from Ghana, a town called Kumasi. Nice to be here with you too.
Dr. Osei Tutu, will you be able to just give us an overview of sickle cell disease and the importance of screening?
So hi, everyone. My name is Dr. Lawrence Osei Tutu from Ghana, and I'm happy to share with you screening regarding sickle cell disease in this series. So we'll be looking today at how sickle cell disease is typically diagnosed when there is no newborn screening, why is early diagnosis of sickle cell disease that important, and why newborn screening for sickle cell disease is also important. Then we'll look at a few challenges associated with newborn screening that we have come to know. And now we can diagnose our newborns and screen them, how to improve that in Sub-Saharan Africa. So we do know that a little under 500,000 kids are born with sickle cell disease annually. And every 3 out of 4 of these children are actually just found in a belt from Senegal to Madagascar in Africa. And we know between 1 to 3% of newborns in this geographical band do have sickle cell disease. Now, newborn screening for sickle cell disease is actually conducted routinely in countries like US, in Europe, in Jamaica, where they have the history and the resources to do them. In Sub-Saharan Africa, however, only a few pilot programs exist in countries like Ghana. So no country in Sub-Saharan Africa has really adopted the universal newborn screening program as we speak. Now let's discuss the diagnosis of sickle cell disease. When sickle cell disease is allowed to progress naturally without any interventions, its ugly head rears itself in various symptoms and complications that are life-threatening and debilitating. Naturally, when babies are born, they do possess what we call fetal hemoglobin. And this fetal hemoglobin protects babies against the ill effects of the abnormal sickle cell. However, like a switch, the fetal hemoglobin effects wanes at around 4 to 6 months of age. And when this happens, then we see the typical symptoms developing, although they may vary in their timing and severity among children. Unfortunately, some babies without intervention will die from some of these manifestations of sickle cell disease. And in the past, it used to be very common that children with sickle cell disease undiagnosed at birth will die from severe infections. However, these are coming down with research and science. Newborn screening is thus preferable to testing after symptom onset. So let's look at some of these symptoms and how they develop. So typically, a parent who has a child with sickle cell disease not known at birth would come to the clinic around 6 months of age, complaining of painful swelling of the hands and feet, what we call the hand-foot syndrome or dactylitis. This is usually followed by painful events, bone pain, crunching at night, keeping baby and parents awake. And soon they get severe bacterial infections in the brain, in the lungs, pneumonia, and may die from that, or bacterial infections in the blood as well. And typically, as they grow older from 9 months to 1 year, that is when the typical anemia of sickle cell disease appears. The blood cells are living younger and younger and dying at a younger age between 2 to 4 weeks and lead to a hemolysis or breakdown of the red cells and anemia, and the typical yellowish discoloration of the sclera of the eyes. Also in Africa, they tend to have big spleens, which mop up the good blood as well as the hemolyzed blood, and that contributes to the anemia. Unfortunately, when these anemic symptoms are unchecked, the blood continues to travel at a very high speed in the blood vessels in the brain and other parts of the body, and that can lead to a series of events, a cascade that leads to eventually strokes around the age of 2 years. So given this, we have learned that for a genetic disease with onset in childhood, it will be better for us to know so that we can intervene based on the evidence of research that we have. So in that sense, we have the newborn screening, just like in the advanced countries, they do newborn screening for a host of genetic disorders. So it is a primary screening and confirming that at birth, a person has sickle cell disease. And that is important so that we are able to early on know and diagnose this person and enroll that child in the care program very early before the onset of the symptoms so that they do not develop into chronic complications and, as I have already pointed out, sometimes premature death. It also helps us to have a registry and database of these children and all other patients throughout life. Then we can monitor their disease progression and also help them to adhere to their treatment and have plans for them policy-wise. However, it doesn't come smoothly, especially in a low and middle income country like countries in Sub-Saharan Africa. Obviously, we do have some challenges. Some of the challenges are quite technical because you require some level of expertise, trained experts to be able to make the diagnosis at birth. It is very scientifically laborious with previous tests that we have. And that means that not all centers, especially in the peripheries, are able to offer such high level tests. What it means is that we now have to batch samples from babies and transport it to central laboratories which have the means, the expertise, and the personnel to be able to run these tests. And this leads to delays, obviously, in communicating back to parents. And of course, there are challenges for parents and guardians in reaching these centers, few centers that are able to provide such a service. However, there's light at the end of the tunnel in that science has matured and improved, that they have now introduced techniques that are able to tell the diagnosis of these newborns right at birth, on the spot, if you like, comparable to things like HIV testing and pregnancy testing, for example. So these techniques may use things like how heavy or light the blood cells are, that is called the density, or how fast or slow they move on a filter paper. Or for instance, what I am very used to, an antibody-based immunoassay, which works perfectly well. It's able to tell you whether a person has A, S, C genotypes. So let's move on now to discuss how some countries in Sub-Saharan Africa has piloted the newborn screening program. So let's use Ghana, for instance. We do know that newborns are screened using a simple heel stick at the place of birth, okay? And now these blood spots are put on filter papers, batched and safely sealed and transported to a central laboratory where they use what you call isoelectric focusing, a specific test that is able to differentiate between the different kinds of hemoglobin at birth to screen these babies. And once babies are diagnosed and confirmed positive, because their details are already known, then they are called back to the clinic and then diagnosis disclosed to the parents or the guardians, and the baby is now placed on the care program, including preventive antibiotics called prophylaxis and further comprehensive management. So this process has been going on since 1993, and by the year 2018, there were 500,000 babies that had been screened, approximately, with almost 2%, that is 2 out of every 100 of these babies being confirmed with sickle cell disease from across Ghana. One center has about over 6,000 registered participants as we speak. So currently, we are trying to improve on the electronic data capture platform and maintain a good registry. Throughout the pilot implementation of the National Newborn Screening Program in Ghana, we've learned some lessons. And of course, I believe that there have been some good benefits. One, for the scientific world to know the disease burden of sickle cell disease in Ghana, that we can say that approximately every 2 out of 100 kids have the disease. It has implication on public health, things like enabling primary prevention and public safety as well. And obviously, it has facilitated the early detection of children born with sickle cell disease. And its implication is obvious, that they can now be enrolled into programs of care. However, we have also some challenges, and obviously, their resources are meager. Funding is always competitive. There are so many competing areas of needs in a lower and middle income country like Ghana. Policy implementation remains a challenge because since the end of the pilot, government had agreed to actually have a universal screening program for sickle cell, but it has not been able to be implemented as of now. Obvious reason being funding, and we hope to cross that barrier soon. Once you cross these barriers, then you have to be able to sustain the implementation efforts and run the programs. And again, you need to be able to train people to do that. And we hope that we take advantage of programs as like HIV and like the expanded program of immunization, so that community-based community health nurses can undertake these simple point of care tests. So now, what happens after diagnosis? Obviously, once we diagnose, then we are able to confirm that you have this genetic disease, and that has implication for the rest of the family members, other pregnancies with the same partners involved that are yet to happen. So these help genetic counselors to be able to speak with families and counsel them on the implications of the disease. So first, you must know. And once you know, then you are able to speak and disclose the diagnosis to caregivers, to the family at large. Sometimes you know that children are going through phases of growth. So they'll go to school, they'll go through teenage years, they'll move away from the house. And at all these developmental milestones, it helps us, the caregivers and clinicians and counselors, to be able to speak with families and the individual patients. As they grow, their nutritional needs become utmost, especially for sickle cell disease, where growth can be restricted. Remember that children are at risk of these nutritional deficiencies anyway, even without sickle cell disease. So to avoid that double burden, knowing early on that there is sickle cell disease, then you put emphasis on nutritional support. Of course, the advantage of knowing early is to include such sufferers in a comprehensive care system and provide available comprehensive medical care. So for us, my key takeaways for us this morning will be that early diagnosis, preventive care, and active clinical management can really prevent complications and death. So we must know, and we must know early, that a person has sickle cell disease. That routine newborn screening for sickle cell disease is certainly needed in Sub-Saharan Africa, although the burden of disease is so high, every 3 out of 4 live in Sub-Saharan Africa, routine newborn screening is not universally accessible. And we also know that currently there are new point of care screening technologies that are less expensive available and very, very easy to use by every cadre of healthcare professional. So I'd like to end here. Thank you very much for listening. These are references.
Welcome to the structured interview section of the live stream, where we will be asking questions to each of our esteemed panelists. We will begin by discussing the diagnosis of sickle cell disease. Mr. Pikiti, could you please describe the journey you went through when your son was diagnosed with sickle cell disease?
Thank you so much for the privilege of sharing my story. My firstborn son was born in 2009. So what had happened was he was in and out with high temperatures, whereby the child is just crying, especially it was from 6 months old. Then we were in and out of the hospitals, and we actually were thinking, oh, let's just go to the private hospital. So you go to this hospital, they test for malaria, HIV. Again, you go again back to the same problem, the child with the headache and high temperature, again they test malaria, HIV, without actually considering that. Then towards 9 months, because we had gone about 3 months, that's when my elder brother said, but don't you think this could be sickle cell if we tried to go and check? Because by then, there was a lot of indications of jaundice. He was becoming pale. So in the end, I think it took us about 3 months. That's when we went to the University Teaching Hospital in Lusaka to test for sickle cell. And definitely was diagnosed with sickle cell. But it was that repetitiveness whereby you go here. Last week we were at the same hospital, they tested what is causing anemia, because the child seemed to be anemic. Maybe it's malaria. Did you go to a malaria predominant areas? No. HIV and AIDS, again they test. So repeated, without actually even to the healthcare workers giving an indication to say, if it's not HIV and AIDS, definitely is a child. Definitely don't expect the child to be sleeping around is a baby. So you look at all those things, and it will sometimes wonder to say, sometimes we shouldn't be taken for granted to say, okay, I'm going to the hospital, they will definitely diagnose this. So that was the experience. Dr. Osei Tutu, what difficulties such as misdiagnosis or delays could some patients experience when trying to obtain diagnosis?
All right, thank you very much, Mr. Pikiti. So as you can imagine, practically there are very challenging issues to deal with, both geographical access to diagnosis and to the expertise. So sometimes you may have the experts around who may think that they know a little bit about sickle cell disease. However, the expertise to run the laborious tests become a challenge and become practically inaccessible to many patients. So in that case, then they have to come to the central point in the city where you have the various experts and expertise, and that, of course, naturally leads to delays in feedback and so on and so forth. Many people also, especially for prenuptial or premarital screening purposes, then they may not have access to these experts and laborious tests that will provide them the kind of diagnosis to make the right diagnosis or the right sickle cell status known. And that has caused a lot of problems in my experience, where couples now give birth to children who have sickle cell disease. And as you have said, acceptance is a big problem. Then they start blaming each other. It has led in the long term to broken homes, into children not having access to quality care because it was not planned and we're not expecting it, and they don't get enrolled onto some of these programs. So beyond misdiagnosis and delays, many patients also have poor geographical access to the expertise and access to these laborious tests that can help them make the diagnosis. So it is important to have tests that are simpler, quicker, on the spot to do, that will help us to screen for sickle cell disease. So Dr. Charles, how does the Ministry of Health support and encourage diagnosis of sickle cell disease?
Thank you very much. The ministry in our country, the Ministry of Health supports sickle cell disease through having policies, having a policy for intervening in the space to care for sickle cell disease. So we have national guidelines, and we have, through these guidelines, we have the implementation or the guidance to clinicians on how to care for and to diagnose sickle cell disease. The other support is through building laboratory infrastructure for screening. We have a national laboratory through which screening, nationwide screening happens. And there's a mechanism to move samples from different health facilities to this laboratory. That's another way the ministry supports sickle cell screening and encourages sickle cell screening. Another one is having a policy on premarital testing and counseling. That is something that we've been engaging with the religious leaders, cultural leaders, but also the political landscape has also been engaging to see that we develop a national policy that every people intending to marry, they should have to do newborns. I mean, they will have to do premarital screening and testing. And also capacity building for health workers, training the health workers from the peripheral sites to collect samples, and then building capacity in the lab for testing and interpretation of results. That's the way the Ministry of Health supports and encourages sickle cell screening, and also validating technologies to support the testing in country.
Thank you all for those informative answers. We'll now move on to discussing the rationale for newborn screening. Dr. Seitutu, in your experience, why is it important that patients are diagnosed early?
Right, so thank you very much, Sam. It is crucial for us to know which child is born with sickle cell disease, because thank God for research, we know how the disease behaves, and we know what it means to have sickle cell disease if you do not intervene. For example, we have come to know that children with sickle cell disease are prone to dying from infections even before their first birthday. So knowing this fact, once we know that a child has sickle cell disease right from birth, then we institute certain interventions or measures, including penicillin prophylaxis, which are antibiotics that are given to these children so that severe bacterial infections do not come their way and take their lives. So it is important to know this, and also to keep them together and know their progress through life, improve their quality of life, and limit the effect of their disease on them. That is to say, provide comprehensive care that will limit any complications that come about later in life. And also, I find it is important for policymakers to know and have data about these children and patients and their families with sickle cell disease, so that they can plan their programs for them, they can implement policies. And once we are able to institute newborn screening, then we know exactly how many we are dealing with, so that policymakers can have good data for their programs, and also to answer certain research questions that we need to know. And for the families themselves, once you are able to come together as a group by knowing that your child has sickle cell disease, then you can begin to share information across. And no one is a better advocate than the family or the patient or the parent who has a child with sickle cell disease, teaching each other how they are living life, how they are going through each experiences of sickle cell disease in life. And for us as clinicians, once we know that a child has sickle cell disease, it prompts us what to do when these children appear, or in their adulthood appear to us in our clinics in their acute state or in their chronic state, and we can quickly put in intervention to save their lives. And I have mentioned before that once we have these patients also, then we can work together future interventions like clinical trials so that they can partake in them, or when they are good interventions like the hydroxyurea therapy by Novartis, for instance, then we can know how to reach these children who have sickle cell disease, for them to be part of these programs. Thank you.
Yeah, thank you for highlighting the importance of early diagnosis. Mr. Piketty, how has early diagnosis changed the sickle cell disease journey for patients and their families?
Thank you. Actually, as they always say, early diagnosis means better prognosis. From my experience, working with two boys with sickle cell, following each other, the first one, we started him on hydroxyurea at least 2 years, when it was about 2 or 3 years. And the treatment has been going on. The best thing was, we were in all this doubt. We don't know what is happening. Could it be because it's a case? Could it be witchcraft? You know, as Africans, we start thinking about all those things. So the moment we knew to say, this is what is happening, then the lifestyle actually just came, boom, it changed. Because everything now was focusing on what is it that we are going to do to improve this child's life. Meaning, the moment he actually started giving the treatment, even things that were coming as when he has a crisis, we were able actually to manage and to do that. The same thing applies to other parents that have experienced with, who have had their children screened earlier. They are able to manage their children better than those whereby they don't actually know, because here is the life of a child that is being at stake, because you don't know what is happening. If the child doesn't have HIV, the child doesn't have malaria, is it witchcraft, as we always become suspicious until you find out. So if you know, just like HIV and AIDS, people used to refuse to be tested because they were scared to know. But once they know, then they were able to go on treatment and they lived a better life and a longer life. The same thing applies with sickle cell. Sickle cell have come to look at it personally, from the family experience, from the people I've spoken to say it's something that is manageable, but you need to know as early as possible, because you can't be running after trying to treat something you don't even know. In the end, that's where people become suspicious. But again, early diagnosis, what about acceptance? Because in my case, it was because we have sickle cell in my family. My wife started to say, no, in my family, we don't have sickle cell. In my family, we don't have sickle cell. But again, it comes whereby you are diagnosed and screened early. Do you understand the things that you are going to go through? How are you going to pursue this? That's where now, as it comes more of like parent-to-parent support, whereby you help the person to understand the situation so that they will be able to learn and know that this is a lifelong type of illness, and it will take consistency and perseverance in order for you to go through this. Otherwise, if you get defeated just by the time you are diagnosed, then you're not going anywhere.
Thank you for sharing your personal experiences. Dr. Kiyaga, how do you feel early newborn screening has benefited society in your region?
Yes, as Mr. Piketty has said, sickle cell disease is not only a disease. It impacts all sectors of life or of society. It is a social problem, it's a cultural problem, it's an economic problem. So with newborn screening, most of these challenges are alleviated. If you discovered your child as early, you'll be able to provide care. So society, when a child is suffering from sickle cell disease, the entire family is impacted and the society. So if you provide care, that means that this child will not inflict such a burden to the family, both socially and economically. So it benefits the family by alleviating all the troubles, the social and economic troubles society would go through because of this child who has been impacted with sickle cell disease. So early screening is very beneficial for many reasons, that the health and well-being and quality of life of the patients or the sufferers or the warriors will be better. They will be productive in society and contribute to the well-being of society, as well as alleviate all the social troubles, like family, broken families and marriages just because of a troubled, non-diagnosed condition of sickle cell. So it is a very beneficial intervention for society, both socially and economically, as well as the entire well-being of society.
It seems many of those regional benefits are the same for the wider sickle cell disease community. Newborn screening, however, isn't without its challenges. Dr. Kiaga, what challenges have you faced implementing a nationwide newborn screening program for sickle cell disease?
Yeah, the biggest challenge is actually around funding, because sickle cell is one of those very neglected diseases and usually underfunded largely by governments, and even the health development partners are just coming out to do something, as well as other stakeholders. So you'll find there is not enough resources for newborn screening, and the newborn screening to have the real impact needs to be universal, that every child that is born, it's a policy that is tested within their first few days or weeks in life, so that interventions begin there. So funding has been the biggest challenge. But also there are other challenges like cultural norms. Cultural norms where, for instance, a baby at birth doesn't have a name, and they will have a name after they have had a family meeting. So identifying this child and properly associating the child with the results eventually becomes a challenge sometimes. But also, when babies are born, they are born in big hospitals, and the mothers or the parents stay far away from there. So you get the results back to the facility, but the patient or the parents are far away. They don't live in that same nearby community. So relaying back the results to the clients has been another challenge. But also when the results come, interpreting them and getting the families to accept the situation, especially when a child is positive and it's a bombshell to them, they knew nothing about it. It goes through a ton of counseling and rechecking the family members before they come to terms with the situation. That is another challenge that usually you would face with sickle cell screening, but also resources for capacity building for health workers who do this. And also after you train, there are also transfers within and without the facilities, and also their health work turnovers. Now those you have trained, after a few months, they have been transferred, or they have moved on, or they have been changed to another station. And then you have to keep retraining and building more capacity. And if there are no resources sufficient to do this, you always find challenges. So those are some of the challenges we face as we implement, but also health system adjustments and attitudes of health workers to adopt this new service of newborn screening and eventually rerouting the patients into care. All these are issues that have to be thought through as you're planning newborn screening programs.
Building on that answer, Sam, what changes to the healthcare system would alleviate the challenges experienced in early diagnosis of sickle cell disease?
Overall, the implementation of comprehensive national programs for the prevention and management of sickle cell disease is needed. Newborn screening programs that are designed to further potentiate the activity of existing clinical centers devoted to sickle cell disease, improve referral systems or networks, and to improve access to patients to highly specialized and comprehensive treatment after diagnosis. This can be achieved by improving the coordination of the initiatives and access to newborn screening facilities. In support of these activities from national governments will no doubt increase the awareness and understanding of sickle cell disease among stakeholders and further optimize the uptake of newborn screening. These are ambitious but feasible goals and further effort will be required from all professionals involved in the implementation of newborn screening initiatives. Dr. Kiaga, what key learnings would you like to share with us and other nations, regions regarding the implementation of a newborn screening program for sickle cell disease?
Newborn screening for sickle cell disease, the lesson that I would want to share with other stakeholders who want to roll out national programs is leveraging on already existing programs. Do not bring up newborn screening to be a standalone. It needs to hang around programs that have already been existing. For instance, HIV programs, especially for early infant diagnosis, where babies are being tracked for testing very early in their days of life. So you can leverage on this so that you can be able to roll out the program more successfully. But there are other programs to leverage on also, like the expanded program for immunization. This is a routine program that has been there for years, and people are used and have built a culture around it that they know that children will have to go for immunization. Hanker and piggyback on it so that you can be able to catch the babies for newborn screening by riding on the already existing systems, as well as norms that have been built over years for sickle cell, for immunization to roll out newborn screening. But also you need to engage the administrators. It's not one thing that you go and train health workers and you think this will work out efficiently, because it's not only about screening. It has to come back with how do you deal with the results when the results come, and how do you deal with those patients who need to receive care. So look at it in totality. Bring all stakeholders on board, including administrators and leaders in these health facilities, and let it be owned by everybody. Don't just pick a few health workers to work with to do the screening, and eventually results come and they cannot be made use of. Make sure everybody is on board. Let everybody understand the importance of newborn screening, and let everybody be involved. It is important to continue supporting patients post-diagnosis. Sam, what support is available through GASDO or other patient association groups to those who have recently received diagnosis for sickle cell disease?
Thank you, Dr. Kiaga. GASDO's work in partnership with national and regional sickle cell disease organizations, healthcare providers, and other necessary collaborators brings the opportunity for patients who have been confirmed to have sickle cell disease to receive appropriate care through the development and dissemination of the clinical care guidelines. So GASDO works very closely with healthcare professionals to be able to provide access to specialized treatment centers, and also be the supporting implementation partner when it comes to patients being able to access medicines, and also working closely with other stakeholders and partners to be able to support the patient's needs. Mr. Pikiti, as part of the patient advocacy group, ZACCAFF, how would you empower persons living with a genetic disease, such as sickle cell disease, take an active role in management?
Thank you, Sam. ZACAF, as in Zambian Childhood Cancer Foundation, we work with the children with life-threatening blood disorders, including sickle cell and bleeding disorders like hemophilia. We started as a parent-to-parent support group, whereby I'm a parent, I've had this experience. What is it that I'm going to share to this other parent in order for them to actually cope with this situation they have found themselves in? Remember, I mentioned earlier, here you are struggling to accept the situation to say, my child has been diagnosed with sickle cell. What you understand by sickle cell is those sickly children, those children who are in and out of hospital. Do you understand? So in that case, what we have been looking at is whereby it's not the end of the world. It's not a death sentence as people call it. So our role as a parent supporting the other parent is whereby you go there to lighten up the burden, to say, my friend, we are in the same situation, and that way it helps with the parent to explain to them, to say, yes, my child has been on treatment for this long. Look at him, he's not stunted. The last time we had the transfusion was 3 years ago. In your case also, this is the same situation that can happen. And in that regard, if you have access to treatment, whereby even if there is no hydroxyurea in the hospital, there are some of the places where you can actually get the hydroxyurea to help your child cope with this situation at reasonable prices. Because it may look that it is expensive, but it makes life easier for you as a parent. So one is with information and helping them to understand the condition in which they are. Two, help them to actually access the treatment at affordable prices so that actually they will be able to cope with that. And as I said, this is it's a lifestyle. I mean, it's a lifestyle. So when the child starts coping better and living a better life with less crisis and less transfusions, then your life also as a parent becomes easier. So as a result, the empowerment comes more or less like to say, let's look at it from the social aspect, as Dr. Charles mentioned. School, your child will be going to school oftenly if the child is able to access treatment, as is on treatment consistently. Two, if you are the person who, and you are a businessman, for instance, you work at the market, if you're a mother and you sell at the market, economically, if the child is in and out, it will affect you. If you make $10 per week, you won't make $10 if your child is in the hospital for a week because your child has a crisis. So it's a mindset. Let's change the mindset to say sickle cell is a lifestyle and one can live strongly as a child, and especially if early diagnosed and managed consistently, the child will be able to cope and live a normal social life, just like any child with diabetes, any child with HIV and AIDS. And a parent will be also be able to support the child more or less like holistically. Those are some of the issues that we deal with. Then furthermore, we are looking at the parents whereby the whole stigma around sickle cell has been created. When we hear about sickle cell, oh, these are sickly people. So it's also trying to break those barriers and myths so that actually that stigma can be eradicated. Because already, the moment you just hear sickle cell in the rural area, you find to say, no, the child won't even reach 15 years, the child will die. While there are other children even say in the United States, even in well-to-do families, they are able to live, even with simple nutritional life type of support that is readily available within the community. So it's myths, breaking those barriers, and also encouraging them to go to access the treatment, and also to encourage them to say, if you are consistent with this, socially you will benefit, economically you are the one who is going to benefit. Thank you so much.
Thank you. And Dr. Osei Tutu, from a clinical perspective, how does this help the long-term management of sickle cell disease for individual patients?
Thanks, Sam. It's absolutely crucial for any patient or any client living with any chronic disease, much so a genetic disorder, to be, how do I put this, his or her own physician. So they best understand what's happening to them. And when we are able to empower them, then we are able to come forth and even go on, like Mr. Piketty has demonstrated, to advocate for better situations for themselves, to policymakers, to other groups, as well as to NGOs and other huge pharmaceutical companies who are now able to put in place certain interventions to assist them. The individual with sickle cell disease, regardless of his or her level of formal education, must well understand the implications of the disease right from the word go, right from infancy, and be able to adapt and live a certain lifestyle that puts quality in his life and, limits the gap between, if you like, a sickle cell patient, as we already know, who has experienced complications and debilitating effects, between that person and the typical person without sickle cell disease or any chronic disease. For instance, in the clinic, it is important for a sickle cell patient to be aware of the kinds of treatments that he or she is on, what kind of pain medications he or she does very well on, why it is important for him or her to carry a simple information packet of what medication and what works well for her in case she finds herself in another environment. Because remember, they have to grow through various phases of life: infancy, childhood, teenage years, at young adults, old age. And all of them have different kinds of complications and risk factors.
Many thanks, everyone, for your answers. We will now move on to the live Q&A section of today's live stream. Thank you all for being with us throughout this session. And we are now entering the Q&A section, where we have had a few questions from the audience on Facebook. And this is actually to the panelists, and we'll just go straight onto it. If the panelists can have their videos on as well, and their, so that we can see them. And without any fashion or any order, probably I'll just go straight to Dr. Osei Tutu. A question here: is preventative antibiotics really needed for Hill stick test?
Right, thanks, Sam. So just to clarify, the prophylaxis or preventive antibiotics is given once we have diagnosed a child of sickle cell disease at birth, because we have said that this disease makes these children prone to severe bacterial infections that can actually kill them. So in a clinical trial that they did, one of the clear evidence was that when we institute such a preventive measure, then we are able to save many of these kids from premature death. So the antibiotic is not required during the process of the test. No, it is only given once we know you have sickle cell, because we have learned what sickle cell can do in terms of infections. And we know, like, penicillin prophylaxis is very useful. So depending on the country or the area you find yourself and the kind of resources, healthcare resources available to you, and the kind of general population health lifestyle, we can continue this prophylactic antibiotics, sometimes even through adulthood to 18. Others also stop it a little bit earlier. So that is a clarification on that. Thank you.
Thank you, Dr. Tutu. And I think this next question is posed for all panelists, and it touches up on screening itself and what happens after screening. So the question is, what are patients' concerns, or parents' concerns, sorry, what are parents' concerns when it comes to getting their children screened? We can have it in a clinical perspective, a parent perspective, and also a programmatic perspective from Dr. Kiaga. So I'll probably start with Mr. Pikiti. What were your concerns when it came to your children being screened?
Thank you, Sam. I think initially it's whereby, as I mentioned, you don't know, you are in suspense. You have no idea that such a thing actually is going to happen to my child. So it becomes more of like a try and error based on the challenges that the child is having at the moment. So when it comes now, when the full diagnosis is done, then again it comes more or less like a shock. A shock, and which requires actually that level of acceptance and typical reflection to say, how has this happened? How are we going to put through all these things? But at the moment, most of the people that I've known of having the child being screened or diagnosed, they don't know it. What prompts the screening and the diagnosis from that early stage is because of the experiences the child had. Maybe it could be malaria, temperatures, things like that, as I mentioned. So all in all, it's what prompts. There isn't any suspicion to say, no, my child will have sickle cell. Because even from the beginning, no, it's a child is born, looking very fine. But once it's triggered by the other infections, then it becomes a problem. That's when you start discovering. Thank you.
Thank you. Dr. Tutu, maybe in around 30 seconds, on a clinical as a healthcare professional, what did you see as concerns from parents?
Well, I think mainly it's also cultural and exposure and education. When I say education, not schooling, but for us to be able to reach parents and for them to understand why we need to do that. Once we're able to do that, we're able to sort of overcome some of these cultural barriers that people are naturally feel that newborn babies are healthy. So why would you want to go look into things? But they now have to understand why we do that. So if we educate the public more, then we can overcome such barriers. Otherwise, I haven't met other situations which prevent people from undergoing such a test in their newborn babies.
Thank you, Dr. Tutu. Dr. Kiaga, in 30 seconds as well, on a programmatic perspective and looking at how you've implemented a program in Uganda for newborn screening, did you have any challenges when it comes to parents' concerns about their children being screened?
Yeah, there are always those challenges, especially due to infidelity or failure on both sides to come to terms with the result. So sometimes the parents think this can open up a can of worms, just in case this child turns out to be positive. What does it mean? Will I still be accepted in that house? So the mother can be apprehensive from doing the test just because of the fear of the result, of the outcome, whether the husband will be able to come to terms and whether they will not interpret that as out of infidelity and result into broken marriages. So that has always been a concern. And where you screen and you get the results positive, sometimes where the parents could even tell you, please don't give me these results or give me another set of results. These are rare, but they do happen and they are really concerns. And counseling has to be done properly. And usually the men tend to push the burden or the blame to the women and sometimes even walk away on them just because they have this unhealthy baby and they think it's a problem of the woman. So that has always been a concern.
I think what you've touched upon also goes to this next question, and I'll have yourself as well and Dr. Tutu address this one. Following newborn screening, are there channels available for emotional support for caregivers of babies that test positive? I can have you, Dr. Kiaga, just continue based on the previous point and address this particular question, and then we have Dr. Tutu as well give on a perspective, a clinical perspective.
Yes, of course, the health workers have been really trained in counseling, genetic counseling. So they provide that a primary messaging to the parents of what it means, what are the implications and so on. But also their patient group. Their patient group within the communities where the parents come from, where families are going through the same, where they become a source of support to the newly discovered families, and to encourage them and give them hope that this is not the end of the tunnel. We have this problem, but we have progress, we have come. And we also have parents within the national program. We also have parents with sickle cell positive parents who are part of the program, who are actually supporting the patient group and making sure if there are complications, we also send them to the field to go and talk to these mothers. So there is also psychosocial support to these mothers within the program.
Okay, and I think on your next answer, you can just check on your voice. I think there was a little bit of an issue there. I think that should be okay. Dr. Tutu, you can raise, do you have a comment on this one, this perspective? And I think we've seen Mr. Pikiti's hand raised up as well. He would like to add up on that.
Right, thank you, Sam. So yes, absolutely. One of the key roles of a comprehensive care center, that's why we call it comprehensive, is this psychosocial support. So the emotional support for both parents and the person living with the disease and other family members, including siblings. And remember, we have to do genetic testing and so forth. And so all these are part of the comprehensive care. Remember, even pain control or pain treatment goes beyond just giving physical medications to the patient. You have to also provide emotional support, psychological support, and sometimes what we describe as spiritual support. So it's a holistic approach to taking care of these patients. That is why it's important that they are part of such a comprehensive care center. Sam, if you don't mind quickly, I see that there's a follow-up question on the penicillin. Should I go ahead and answer that?
Yeah, sure.
Because,
yeah,
the viewer on Facebook wanted to know, in case of penicillin allergy, which prophylactic antibiotic is recommended? I think in our practice, evidence has gone in for one antibiotic we call erythromycin. It may work in place of penicillin allergy. However, remember, this is only one level of care or prevention. We can also institute what we call crash packs. So in case of fever, it is either you get yourself to your acute care center within 1 hour and get antibiotics started, appropriate antibiotics started and care, or your doctors can give you crash packs that you can take in case of fever before you get to a hospital. So we can put in several measures, even when we can't do the prophylaxis for allergy reasons, for instance. And he also wanted to know about hydroxyurea therapy duration, and you can speak to your clinician about that, but really it is for life. We only suspend it for other reasons, including what we call side effects, or because you are going to get pregnant. Otherwise, when you're on hydroxyurea, it's for life. Thank you, Sam.
Thank you, Dr. Tutu. I think, thank you for actually following through with that question. And we have a lot of questions which are coming in, and I'm sure not related to screening. But I mean, because of time, we'll have to specifically answer some of the questions related to screening and put it as a whole. I would just like to get all of your three perspectives. And I think this is one question which will cover some of the aspects that we're talking about today. What would universal newborn screening across Sub-Saharan Africa mean to you in your role, either as a doctor, patient advocate, or minister? We can start with Mr. Pikiti as a patient advocate. What would universal newborn screening across Sub-Saharan Africa mean to you?
Yeah, thank you, Sam. I think we we have to learn from the HIV and AIDS community. Everyone from the 80s, know your status, was breached and was more or less like made available to everyone as a way of actually going forward to have screening. I think that's where we need to be making noise a lot so that actually people will get to know. Instead of having a prompt type of screening, it has to be more or less like a mandate for every newborn child within in a country to be screened just as they screen somebody with HIV, just as they screen somebody with TB from the initial perspective. This will lessen the burden for everyone, for the parents, for the treaters, and actually even for the governments and hospitals from overspending funds. I think for me, that's the perspective I can look at it from.
Okay, Dr. Osei Tutu.
All right. I mean, yeah. I mean, as a clinician, obviously, I would love to know. I would love to be monitoring and managing a very healthy child right from birth to adulthood, and that goes without saying to every clinician. So it sort of relieves a lot of pressure on resources in the hospital. If I'm managing a hospital, I wouldn't want to spend too much money on blood transfusion services, for instance. It costs a lot of money. I do not want to also keep my beds occupied for so long, so can have empty beds with high patient turnover, then we can have more patients coming. And if you are able to know this right from the start, know someone's status, then you put in preventive measures so that the pressure on these resources, including very, very limited experts and doctors and nurses to take care of these children, everything will sort of be in a manageable situation for everyone. So sitting in the clinic is a very useful tool intervention for both public health and for clinical care.
Thank you, Dr. Tutu. I know we don't have a lot of time. Dr. Kiaga, 10 seconds, please, before we have a close on a Ministry of Health perspective in regards to newborn screening in Sub-Saharan Africa.
Yeah, if we reach to a point that we can have newborn screening universal for Sub-Saharan Africa, I think it will be a great relief. First and foremost, for that to happen, there must be resource mobilization and ownership. I think the drive to have universal newborn screening for sickle cell will have to begin with engaging governments and key stakeholders to fund the intervention. And because I mentioned even in our earlier discussion that the biggest challenge to newborn screening is funding, if that issue of funding and country ownership is sorted, then universal newborn screening would solve problems for everyone. I agree with Dr. Tutu, how it would relieve the burden on the hospitals and the expenditures that will be met on inpatients and frequent transfusions and so on because of late diagnosis and children who are discovered when it is late. So if we discover them early, it's light for everybody. So I really think this will be a great breakthrough. It will be a big breath of fresh air for the entire region, and I greatly encourage it. And any drive towards that will be in the right direction.
Thank you, Dr. Kiaga. And this has come to the end of this session. And we would like to thank the viewers for being with us on this time. I wish we had more time to have this discussion, but this has come to the end. And to let you know that we will be having our next series, which will be in January 2022, which will be entitled S is for Stigma. And we hope to see you there.